coil embolization. What happens inside the angio suite? Perspective for the radiologist. Dr. Mohamed Elgabaly, please.
Thank you very much. I just would like to get some permission. I see a room full of interventionists, so I have maybe a little bit better presentation, maybe more worthwhile of everybody's time. So I'm going to talk today briefly. I know everybody's busy and getting ready to leave. Got a few pictures on the transorbital route for treatment of cardiac cavernous fistulas, and how we can utilize the ophthalmic veins to get access to the fistulous pouch. So basically, the cavernous sinus is a contiguous series of venous lakes enclosed between two layers of the dura, and I don't know if you can see is there a pointer here? Okay. Between two layers of the dura, and you're traversed by critical arteries, the carotid artery and the cranial nerves, namely the trigeminal, the fourth, sixth, and third nerves. When we get a fistula, we get a communication between the artery and the vein. Fistulas can be classified according to whether they're spontaneous or traumatic, whether high flow or low flow, or whether they're supplied by the internal or external carotid arteries. There's also the Barrow classification. You see here type A, which is basically the direct type of fistula, basically a hole in the carotid artery opening up into the cavernous sinus. And then that type B, where you have the meningeal branches of the internal carotid artery opening up into the cavernous sinus. Type C is the external carotid artery branches into the cavernous sinus, and type D is the branches of both opening of the internal and external into the carotid artery, into the cavernous sinus. Once the cavernous sinus gets pressurized, the superior ophthalmic vein becomes engorged, arterializes, and can provide access to the cavernous sinus to occlude it if there's a fistula is present. How do I go forward? Oh. The presentation of a carotid cavernous fistula is relatively indolent. As the sinus gets congested and reflux starts occurring in the ophthalmic veins, you get the ocular symptoms, conjunctival injection, glaucoma, that kind of thing, and it can progress to compression of the optic nerve and optic nerve atrophy and loss of vision. This, if the outlet is the ophthalmic veins. If the outlet is the cortical veins, then you run the risk of intracranial hemorrhage and, of course, milder symptoms like headaches and seizures. بعد إذنك هتحرك إزاي السلايد اللي ورا؟ خلاص ماشي تمام. فين بقى؟ خلاص ماشي شكرا. In terms of imaging, usually these are picked up on cross-sectional studies. You see on the left side there's a CAT scan with contrast, and you can see a dilated ophthalmic vein with the black arrow, proptosis, and lid edema. And then on the MRI on the right side, you can see where the white arrow points. There's a prominence of the cavernous sinus on the left side. There's enlargement of the left lateral rectus muscle, and there's some engorged venous structures within the intraconal and extraconal fat. In terms of access to the cavernous sinus, there are multiple routes. My favorite route is usually the inferior petrosal sinus. If this is not available, there's a superior petrosal sinus, there's the pterygoid plexus, which are much harder. There's the facial vein, superior ophthalmic vein, and less commonly the inferior ophthalmic vein. So we're just going to show a demonstration case. This patient was presented with conjunctival injection, and the ophthalmologist was suspecting carotid cavernous fistula. You see here, there's a fistula between branches of the meningeal branches of the internal carotid artery and the cavernous sinus. And you don't see any inferior petrosal sinus, so this gives us a hard time getting access into the cavernous sinus. But we do see here a dilated ophthalmic vein. Sorry, let me read that back. Here with retrograde flow, and this was promising for access. Now, this is the other side, and you can see there's also contralateral supply from the contralateral left internal carotid artery supplying the right cavernous sinus. We then shot the external carotid arteries, same thing. Both external carotid arteries are supplying the fistula. This is the affected side, the right side, and this is the left side as well. You see the crossover supply to the cavernous sinus. So we knew the inferior petrosal sinus was occluded. We tried to probe a few times. We couldn't get past it. We thought we'd try the facial vein, and you can see here, I don't know if you can see my arrow. There's the catheter getting up the facial vein, over here getting up too, but we always get caught around the trochlea as we try to get into the orbit. So then the plan was to attempt the superior ophthalmic vein access, and we asked our neuro-ophthalmology surgeons to help us out. This is a long video. I'm going to try to go through it quickly. So basically, they anesthetized the lateral aspect, the superior lateral aspect of the orbit with epinephrine lidocaine. An incision is made, and then the dissection is made through the periorbital fat, the orbital septum, until they reach the level of the superior ophthalmic vein. I'm sorry, I'm going to skip the video a bit so that we can, which I can't. Oh. So then, yeah, the section continues down to the fat until the vein is reached. The section continues, getting close. There the vein is identified, and you will notice that the vein is highly pressurized, and the ophthalmologists were a little scared when they tried to access it. We asked them to put in a microwire and a 4 French sheath. Let me show here, get through that, sorry. All right, there it is. You see it here, the engorged superior ophthalmic vein. So now they're trying to access it. Well, first, obviously, you have to mark it, isolate it. Here it is. So once he opens up, boom. Right, so it's a highly engorged superior ophthalmic vein. So then we asked them to put a wire through and try to put a micropuncture sheath. They eventually had hemostasis. And then this is the sheath going in. I'm trying to be as gentle as they can. All right. So in terms of access, again, this is what we did. So basically access to the superior ophthalmic vein. The advantage of the superior ophthalmic vein is that it's straight, it's valveless. When it arterializes, it's fairly robust in terms of exposure to injury, and it provides a good route to the cavernous sinus. So this is again what we did here. You can see here the sheath going in. There's the ophthalmic vein. Here's our wire, ophthalmic vein up to the cavernous sinus, followed by our 4 French sheath. Yeah, another approach is basically to take a chunk of bone out, like the superior lateral aspect of the orbital rim, but that carries more risk of injury. So then we, once we got in, we did an angiogram. It's confirmed we were inside the ophthalmic, inside the cavernous sinus. And then we started putting in some coils, and we thought we got it. We did the angiogram, and there was still persistent shunting. So now we lost the ophthalmic vein access. We don't have a petrosal access. We tried the facial vein, and that didn't work. So we, as a kind of a desperate attempt, we went to try to access from the contralateral side. So you can see this is the left side. This is just a regular diagnostic catheter, and then a microcatheter SL10 and a synchro, crossed across midline into the sinus, did a confirmation angiogram, and we knew we were in the sinus. So then we continued coiling, and now it looked much better. The fistula was gone. And this is the right side. I think this was the left side. So in terms of complications, sometimes it's not possible. Getting into the ophthalmic vein may be a little tricky. That's why we usually use the ophthalmology surgeons. You may end up with orbital retroorbital hematoma, the damage to the structures within the orbit, the globe, or the orbital contacts, or of course infection, just like any procedure. And then the added inherent risks with transvenous embolization in terms of cranial nerve palsies, dissection, vessel perforation, and embolic complications. There are a bunch of papers out there. They all quote almost complete cure, or at least 90% cure, extremely low chance of complications, and it kind of proves the point that the ophthalmic vein may provide a safe access to treating cardiac cavernous fistula. Thank you very much.
Now we come to the symposium that is attached to our meeting from Siemens. Please, Siemens people, please come to the... Thank you.